Okay. Good afternoon, everyone. Welcome, and thank you so much for joining us today. This is a joint briefing with the Health and Social Services Subcommittee on Appropriations and the Public Health Subcommittee of Health and Government Operations. Today, we're going to be taking a deeper dive into our home and community-based services programs here in Maryland. And we want to talk a little bit about the patients that are served and the challenges that we are hearing from our constituents in accessing some of these really important programs. Before we begin, I just want to acknowledge that in addition to our esteemed members of both subcommittees, we're joined in the audience by my district mate, Delegate Aaron Kaufman, who has a strong interest in these programs as well. He can't stay for too terribly long, but he wanted to join us for a bit of the briefing. Welcome, Delegate. No conversation on these waivers can really begin without the sincerest thanks to the immense work done by the Health and Government Operations Chair Pena Melnick, Vice Chair Cullison, and our Chair of Public Health, Bagnall. They have done extraordinary efforts over the years to address some of the systemic challenges that are facing these programs, and I really thank you all for the leadership in this area among so many others. So let me start by sharing a little bit about why I am personally interested in these waivers. So as a subcommittee chair on health and social services on appropriations, we spend a lot of time looking at numbers. The number of people on Medicaid, the number of people in different waiver programs, and the number of people seeking access to programs but not able to get it. But behind each of these numbers are stories of our constituents, families who have loved ones who are aging and have strong preferences of being able to age in place, but they don't have the means to do so. Personally, my own family is in the process of navigating this very challenge. My mother is aging. She has dementia. And ironically, she is a retired dementia care nurse. And so over the last 6 months, we've actually been, as her disease has progressed very quickly, we've had to navigate these same challenges that are faced by so many of our constituents across the state. And in doing so, my own family learned so much about some of the shortfalls of the programs here that we're going to discuss today, as well as the massive and growing wait lists for these services. This system is not at all transparent. Patients don't know how long they'll be on a list for needed services or if they'll ever qualify. And there's no meaningful way to check the status of where they are in line. But I want to emphasize a really critical point here. This is not just a health systems problem. This is a health equity problem. In many communities of color, there is a strong cultural preference for aging within the family home and not in institutional settings. And this is rooted in many factors. Intergenerational living and care is a big one, but also in systemic challenges within our healthcare system that has led to a well-documented history of disparities in the quality of healthcare received by patients of color. It is understandable then that we see a huge disparity in the racial composition of nursing homes, where Black patients account for only 15% of all nursing home residents. Latinx residents comprise 6%, and white patients account for an overwhelming 79% of patients. Well, why is this important? Our healthcare system offers very little support for aging. However, Medicaid long-term care has long offered coverage for patients who require nursing home level services. These waiver programs allow individuals who wish to age in place an opportunity to do so while still receiving support from Medicaid in their preferred care setting. If we're only focused on ensuring that our healthcare system prioritizes coverage for nursing homes, then we are leaving out a massive segment of the patient population. That is a health equity problem. I'm grateful for the opportunity to hear from our friends in Medicaid and the Department of Health, who can share a little bit about some of the immense work that they are doing to partner with us in solving these immense problems. And I'm extremely grateful to have the opportunity to have our subcommittee partner, the Health and Government Operations Public Health Subcommittee, to continue our work together. So with that, I will turn the mic over to Chair Bagnall for her opening remarks. Thank you.
Thank you very much, Madam Chair. And I want to thank Madam Chair, Madam Vice Chair, and the Appropriations Committee for the invitation to today's briefing and for your partnership in this work. I also want to thank the department and the new administration for your commitment to really take a deep dive into our entire Medicaid system, looking at how to modernize, how to more effectively implement, and how to ensure that access and that equity in our system. We look forward to working with you and the department on addressing any issues in the delivery of services for our most vulnerable populations, and to addressing any needs and barriers to ensure we are investing our state dollars wisely, effectively, equitably, and holistically so that we are achieving our goals and the public health outcomes which demonstrate that meaningful return on our investment. I want to go ahead and take this opportunity to introduce our panel today, the Maryland Department of Health. We have Ryan Moran, Deputy Secretary of Healthcare Financing and Medicaid Director, Tricia Roddy, who is the Deputy Medicaid Director, and Jamie Smith, Deputy Director of the Office of Long-Term Services and Supports. And if you would join us on the panel to start the overview of Home Community-Based Services Waiver Program and update on the Office of Long-Term Services and Supports. Welcome and thank you for being here.
Good afternoon. I was just triggering in my brain exactly what the time was. You can't really tell with the warm weather out there what season it is either, but we'll just put that to the side. Chair Shetty and Chair Bagnall, thank you so much for the opportunity for the Medicaid program and Medicaid leadership to be before you on what really is a critical subject, as you both have outlined in your opening remarks. I want to thank you both for your leadership in this new administration, engaging with us within this particular space. And Delegate Shetty, as we talked prior to this particular briefing, I also want to thank you for sharing your personal connection, the journey that you had with your mother, and then also as it relates to our work across Medicaid. I am going to introduce my colleagues who I'm incredibly proud to partner with and lead along their side on a daily basis. And then I'm going to frame up the agenda, provide some opening remarks, and then we have a robust and meaty opportunity to talk about three particular areas that I think we'll spend our time in today. With me to my right is actually no longer the Deputy Director of the Office of Long-Term Support Services, but is the Director of, or the Acting Director of the Office of Long-Term Support Services, Jamie Smith. You may remember Marlena Hutchinson in your interactions with you or your constituents who served in this capacity. If you don't know, Marlena is now the Deputy Secretary of the Developmental Disabilities Administration within the Department of Health. And then to her right is my colleague and partner in crime, Deputy Medicaid Director Tricia Roddy. And I know that over the course of Tricia's long history and deep expertise in this particular space in Medicaid, you've had the opportunity to work with her, and I'm pleased to partner with her on a daily basis in this work as well. I want to set four sort of framing remarks before Tricia and I turn it over to Jamie to really go through the content of the deck. Since, and you're going to hear a lot about the history of these particular programs, who the state operating agencies are, talking a little bit about some of the challenges related to waitlist registries as well as plans of service and the plans that are to rectify those issues. But I want to frame that there are four different buckets that this administration is really keen on when we think about home and community-based services housed within the Office of Long-Term Support Services. That's really of a strategic priority and focus of us. And that's common themes when we think about how we're looking for both improvements, but intention and attention to this really critical space. The first is we are, as an administration, working to address by building back the infrastructure of this particular office. And that includes staffing, it's looking at processes. Secondly, we also, in terms of this particular work, are being realistic about where we have internal capacity and where we need external capacity to support the work. And you'll hear about that in terms of some of the remedies to some of the challenges that have been faced thus far. Three, we are intentional, or being more intentional, if you will, about interagency collaboration across state government. In this particular space, and I see some colleagues who are here represented from those arenas, the Maryland Department of Aging, the Maryland Department of Disabilities, Department of Housing and Community Development are just some of the agencies that are critical partners for us to advance the work in this space. And then 4, we have an eye to the future. We're going to talk a little bit, and we've already talked about some in bill hearings, about some of the significant changes that are coming that are proposed from the federal government in the home and community-based services space. And we will give you a line into the future about how we think about building the capacity with the things that are coming in our head. So with that, I'm going to turn it over to Jamie to talk about the Office of Long-Term Support Services, which houses our waiver programs, tell you a little bit about that office, walk through some of the top priorities, specifically honing in on the challenges that you both cited in terms of your opening remarks. And then we will talk a little bit about what the future awaits in this space. Thank you for the opportunity to be here.
Good afternoon, and thanks again for having us today. We're happy to be here with you. So as Ryan mentioned, we'll lead off by sharing a bit about the Office of Long-Term Services and Supports, which does manage 23 of the Medicaid fee-for-service programs. We manage institutional services such as nursing facilities, chronic and special hospitals, and hospice facilities, all the way through the home and community-based services, which does include 8 of our 1915C waivers and many other state plan programs. Our office has a total capacity for staffing of 134 staff members. And we work with, Ryan mentioned a few of these agencies, but we work with a number of internal MDH agencies as well as many external agencies. So I won't read them all to you, but they are all listed there for you. So we wanted to differentiate for the committees, the difference between the state plan programs and a 1915C waiver, because there are some unique differences that are important as we're talking through the programs. So we'll start with the state plan programs. So the Medicaid state plan in general is the agreement between the state and federal government on how the state does administer its Medicaid program. It indicates the groups of individuals to be covered, the services that are provided, the methodologies for reimbursement, as well as some administrative activities. Anyone who meets the community Medicaid eligibility criteria can have access to the state plan programs as long as they meet the qualification factors. And moving on to the 1915C waivers, states can waive in these programs certain program requirements, comparability, income and resource standards, as well as statewide-ness. The waivers must demonstrate cost neutrality, which means that it must cost less to take care of someone in a home and community-based setting than it does in an institution. States may cover services that aren't covered in the Medicaid state plan, and states do have the ability to limit the number of waiver participants. Participants do still need to meet the financial, medical, and technical criteria in order to qualify. And with access to the waiver, qualification for the waiver does give participants access to those state plan services. So diving into the 8 1915C waivers that I mentioned, we have, again, 8 of those, and these 3 that you see here, model waiver, home and community-based options waiver, and the medical daycare waiver are all operated by the Office of Long-Term Services and Supports. And they serve specific target groups that we do have listed there. We've also linked to each of the waivers more details about the array of services that are provided in each of the waiver programs, along with the process in which to apply. The 3 waivers that we have listed here, community pathways, family supports, and community supports, are all operated by the Developmental Disabilities Administration, and the Office of Long-Term Services and Supports does have administrative oversight of those programs. We have the autism waiver, which is operated by the Maryland State Department of Education, and the brain injury waiver, which is operated by the Behavioral Health Administration. And again, the Office of Long-Term Services and Supports does have administrative oversight over those programs as well. So while these next few programs that we're going to talk about aren't 1915C waivers, they are very important programs that help to serve folks that are living in their communities. So Community First Choice is one of those. Community Personal Assistance, and those are both state plan programs. Increased Community Supports is a Medicaid waiver demonstration program. And then lastly, we have the Money Follows the Person demonstration, which is important because it is also a demonstration that does help to deinstitutionalize individuals who are in a nursing facility who wish to return to their communities. So moving on to some enrollment data, we did list here all of the various programs, the current enrollment for fiscal year 23, the available waiver slots, and the registry and waitlist numbers. I will just point out here that the medical daycare waiver and the brain injury waiver do not currently have waitlists. The other programs do have either a waitlist or a registry, and the 3 DDA waivers do share one waitlist for all 3 programs. The community personal assistance, community first choice, and increased community services programs, their enrollment data is listed here. And I'll just point out that these are state plan programs, at least community personal assistance and community first choice are. So we aren't able to limit the enrollment cap, and there is no waitlist or registry for those 2 programs. The increased community services program is a demonstration waiver. It is capped at 100 individuals. So we've also listed here some of the historic rate increases that the home and community-based services have received, going back to fiscal year 2019, all the way through the proposed increase in the fiscal year 2025 budget, which will be 3%. And some top priorities for our office. First, we'll talk about the End the Wait Act. So pursuant to Senate Bill 636 and Senate Bill 622, MDH did prepare a plan to reduce the registry or waitlist by 50% by fiscal year 2028. So just to reiterate, the programs that do have a waitlist or a registry are the DDA operated programs, which are the Community Pathways, Community Supports and Family Supports program. They share a waitlist. The model waiver has a registry. The home and community-based options waiver, often referred to as community options, has a registry. And then the autism waiver does have a waitlist / registry. And we'll talk a little bit more about that on the next slide. Just pointing out the difference between a registry and a waitlist. A registry includes interested individuals regardless of eligibility status, whereas the waitlist includes individuals who have met the technical eligibility criteria. They would still need, once invited, to apply to meet the medical and financial, but they have been at least determined to meet the technical eligibility. Some noteworthy progress that we wanted to talk about today were the increased monthly invitations for the community options waiver. Earlier in 2023, we were sending 300 invitations and had been sending that many for quite some time. And we were able to increase that number to 600 invitations monthly. Increase of approved waiver slots to accommodate the increased capacity for the plan over this next 5-year period. So we have been able to do that in the autism waiver, the community options waiver, and the 3 waivers operated by the DDA. The model waiver is capped at 200 individuals based on its federal authority. So we did not increase slots for that particular waiver, but it is at its max capacity. And I had mentioned that the autism waiver is actively transferring from or transitioning from a registry to a wait list. So the Maryland State Department of Education is actively screening those individuals on the registry and moving them onto the wait list as they've confirmed that they meet the technical eligibility of the program. They do expect to have that transition completed by the end of fiscal year 2024. Also, we've increased case management capacity to support the additional applicants and participants, specifically in the community options waiver, community first choice program, community personal assistance services program, and the increased community services programs. So as of July 2023, there's no longer a wait list for a case manager to help applicants or participants navigate the enrollment process. So we've provided here the table that was included in the Joint Chairman's report that was submitted for the End the Wait Act. So just pointing out a couple of key costs here on this slide. We had the service cost, and this is again over a 5-year period. So that was just $951 million. We had the staffing cost at $34 million, miscellaneous costs, $3 million. So the total cost to implement this over the course of 5 years is estimated to be $989 million. And the general fund share of that is $494 million. So there are some staffing requirements that were included in the JCR. So in order to effectuate this plan effectively, MDH would require 72 additional staff members to do that across the agencies that do support these programs. Moving on to another top priority for our office is the plan of service reviews. So just to quickly talk about what a plan of service is, it is a request for program services that's aimed at meeting a participant's medical needs in relation to the activities of daily living and the instrumental activities of daily living. The plans of service are developed by our supports planners in collaboration with the participants and or his or her representative. And then upon approval for the plan of service, it does become the service authorization. The plan of service backlog does impact those applicants and participants in 4 of our programs. Again, those are the Community Options Program, Community First Choice, Community Personal Assistance, and Increased Community Services programs. OLTSS currently has 11 plan of service reviewers that are decisioning these plans. And as of December, there were 13,799 plans pending a decision by MDH. And there are 4 types of plans: provisional, initial, revised, and annual. And we have those numbers listed there for you. So our remediation strategy, first and foremost, was to build provider capacity to make sure that those case managers were in place to help develop those plans of service. That has been completed, and as previously reported, that waitlist ended in July of 2023. We continue to try to build internal staff resources to make sure that we have staff that can continue to decision those plans. And then some upcoming remedies that will soon be in place is building a system logic to approve certain annual plans of service that meet a specific criteria. We expect that to be implemented in the spring of 2024. And then lastly, we do expect to transition the plan of service reviews to a contractor, and that too will take place here in the very near future in the spring of 2024. And with that, I'll turn it back to Ryan.
Sure, I'm gonna close out the portion of the briefing with the last portion, which is to talk a little bit about the future of the home and community-based services space, as well as the department's work to try to intentionally more partly with our other state government agencies. And we have moved some work at the national level to receive some technical assistance that would bring in home and community-based service experts and other resources that would allow us to execute on these plans, but also bring additional learnings that's shaped and informed by other states. I think it's important here to recognize that when we're talking about this particular space, we're really talking about a continuum of care all the way from pre-Medicaid, where there could be services and supports to individuals who don't necessarily qualify for Medicaid or those on a Medicaid waiver registry and wait list. And there are certain programs and supports also that we can discuss in terms of whether that's with the Department of Aging or others that are within that space. And then Jamie also talked about the full range of actually when individuals move to that HCBS space. And then obviously the institutional services, those are designed to support individuals who cannot safely reside in their homes. We point out this continuum because on the next slide, you will note that there is the opportunity that we're working with in the Department of Aging. If you go to the next slide, is we received a grant for support most recently over the past couple of weeks for technical assistance with Advancing States, which is really the national guru in terms of the home and community-based services space, to think about that full continuum and rebalancing and providing services across that particular well. It will help us, we hope, to look at our technology tools that we have in place, the work and the pre-Medicaid services and support space, as well as I also just want to underscore another important point. We talk a lot about the long-term care workforce, but this workforce in the Medicaid division of Office and Long-Term Support Services was obviously, if it's not known, a critical function of responding to the pandemic as well. And so there's opportunities even internally for us to build back our own public health workforce, and that relates back to the first item that I've mentioned. And then lastly, before we open it up for questions on the next slide, I will just note, and we were talking about this in the full House and Government Operations hearing earlier this week, and Delegate Bagnall, Chair Bagnall, I know that you and I have had conversations related to what's coming from the federal government. The Biden administration has produced what I think we would note as significant landmark changes as part of a proposed rule in 2023 that would transform the home and community-based services landscape. We are expecting the Biden administration to finalize that rule in 2024, so sometime earlier this year. And then What that would mean is the finalized provisions, and again, what you're seeing on this slide are proposed rules. The finalized provision would give us details, but it would also give us concrete timelines that all states would need to come into compliance for. And I note them here because they are some of the things I think in our conversations with all of you that our hopes that we want to move towards in terms of that direction. It's things such as establishing new opportunities to promote public transparency for the oversight, monitoring, quality assurance, and quality improvement in our HCBS programs. How are we tracking quality of services, and how is that, Delegate Shetty, to your point, more transparent in that regard? Requiring 80% of Medicaid payments, state dollars, for personal care and homemade services to be spent on compensation for direct care workers. It will require us to publish the rates of home care workers delivering personal care services. And then, uniquely to this discussion today, it also requires states to be more transparent in their reporting lists on wait lists for waiver programs and the service delivery timelines that they have for these types of services as well. This is just a highlight. We're happy to send you the full proposed rule and full summary of that came out from CMS. We are watching this space very closely because we anticipate, as I mentioned, sometime earlier this year, and then it will give us a timeline in terms of when we will come into compliance for. Many of the things that we're talking about are things that are on our radar, and we're looking to try to build capacity for us to do, but I mention them just because they are significant to the future of this discussion. So with that, Chair Shetty and Chair Bagnall, we are happy to take any questions that you or other members of both of this joint committee may have. And again, thanks for the opportunity.
Thank you so much. Really appreciate the thorough discussion and presentation and all of the important work that you're doing to ensure that these programs are optimized and are really delivering for patients in Maryland. So with that, we're going to turn to questions from our colleagues on the committee. And as is customary, questions that are asked by our Public Health Subcommittee members will be acknowledged and recognized rather by the chair, and vice versa for our members. So if it's okay, I'm just going to begin first with Delegate McCaskill.
Thank you, Madam Chair. Good afternoon, everyone. So congrats to your noteworthy progress, I must say. But I have a few questions. So we see in your data enrollment that there are 26,000 plus people now on a wait list. So how long does the average person on the wait list wait before they hear from anyone or invited to apply?
Yeah, thanks for that question. It's a bit difficult to answer based on a specific timeline because there are categories assigned to those on the wait list that are at the highest risk of institutionalization. So there are individuals who could be added to the registry who are invited in the very next month. If they are at a high risk, after that level 1 screening is completed by the Maryland Access Point sites, then they may be invited very quickly. There are 6 categories ranging from 1 to 6. And those that are in category 6 would have obviously a longer time to wait to be called.
Okay, perfect. So are the individuals notified of what their status is?
They are not
application. Currently. Okay. Last question, I promise. I know it's Friday. So how often does the registry update people who are deceased and who have moved away?
Yeah, and thanks for that question. So there certainly are opportunities for us to do some scrubbing of that registry. That has not occurred since the pandemic has obviously been in place and then of course ended. So we certainly have an opportunity to look at that. And we hope to identify some ways through the technical assistance that Ryan mentioned with MDOA to partner with them and think of ways that we can do that well.
Okay, and so the last part of that, so is MD Think at all utilized to help with that cleanup?
It is not currently used to do any cleanup as far as the registry is concerned.
Okay, thank you. Thank you, Madam Chair.
Delegate Chisholm, go ahead.
Thank you, Madam Chair.
And thank you for the presentation. When we're looking at the wait list, I'm going to assume that a lot of this is bureaucratic and workforce shortage. And with that, how much are we coordinating with Do It and AI to try to help clean up a lot of this wait list? And you just alluded to the fact that there's a lot of people on there that maybe shouldn't be on there, just to try to clean up a lot of the paperwork that may be old, so that we are moving the people that are waiting up and in front of people that really aren't there anymore. Because I know that we have a workforce shortage and it's hard to coordinate the more people. And it seems like this problem is starting to grow out of control because we don't know what's accurate and what's in the past.
Yeah, I mean, I'll take a stab at that. I mean, we've, I think this is probably a policy discussion amongst you all as well. One of the things that we've struggled with in terms of how to manage a registry is that anyone of interest can put their name on that, right? Regardless of when they're going to need services or what their income is or what their level of care needs are. And so that, be honest, I think that's been a struggle of the department as well in terms of trying to explain these large numbers. In 2018, 2019, as Jamie mentioned, we finally implemented a system where we are prioritizing need. So 80% of the people on the registry are based on their prioritized based on need. And we do leave 20% based on how long they've been on the registry. So we wanted to basically not leave them off in terms of accessing services if they've been on the registry for a long period of time. But it is something that I think we would all love to have your thoughts about in terms of how to manage this registry in the future. Because again, you know, anyone of interest, I can apply today, be found ineligible, and tomorrow put my name back on that list. And so this is a challenge that we'll all have as we try to end the wait list and kind of manage these registries.
Thank you, Madam Chair.
Thank you, Delegate. You know, I think it's important to note anecdotally what I'm hearing from constituents is that it is known that this wait list could take 5 to 7 years for somebody to be on it. And so as a result, people are proactively putting themselves on the wait list, knowing that number. And so, you know, I think the screening processes that you're doing, it's really helpful. But when people miss that screening call, there's no way to call them back. Like there's no number, there's no way to find out where you are on the list, to proactively go through the screening process if you've not done it. I know our family experienced that directly. And so I think there's some really critical transparency components that really need to be improved on the front end that could help with some of the registry management. And I would be delighted to work with you on that. I would like to recognize Delegate Heinbaugh for a question.
Thank you, Madam Chair. Thank you for your presentation and for what you do. I'd like to start out with a personal observation. I'll be very brief, and then I have a follow-up question that's related to my observation. A few years ago, I had to put my mother, she was 99 at the time, in a nursing home. She had lived for 40 years alone in the same house. So putting her in a nursing home was an awful experience for everybody. Toughest decision ever made in my life. It was difficult for everybody. Medicaid was paying, I think it was something like in the order of $8,000 a month for her to the nursing home. I often thought, you know, if I could have gotten a fraction of that I could have hired somebody and she could have stayed home, aged at home, and had, quite frankly, better care than she had in the nursing home. My question is there any data out there that shows what it costs for somebody to age at home versus maybe assisted living or in a nursing home facility? And, you know, this becomes critical because old people like myself, I'm at the leading edge of the baby boomer generation. And as your numbers show, this is going to be a bigger and bigger problem. And I don't know if this is true, but I read somewhere that something like 80% of a person's lifetime healthcare costs occur in the last couple or 3 years. So to me, it's just absolutely critical that we come up with some, and I know, and it's very bureaucratic. I experienced that. But I just wonder, are there numbers there that could be used maybe to help justify allowing people to age it at home? And can we do that in a way that's not real bureaucratic? I mean, if you get into, well, we got to have people that are certified for this or that, and I know there's a chance for fraud and abuse, but even at that, it has to be a huge savings overall. Thank you.
Yeah, of course. And thanks for the question. I'll take a stab and then ask Ryan and Tricia to fill in anything I might miss. But yes, we actually leverage the Hilltop Institute as well to assist us with tracking some of those costs. So for each of our waivers and even those state plan programs, we do have per participant costs that help us to evaluate the what those services that person is authorized to receive do cost. So we do that. We also do that on the institutional level as well. Again, leveraging Hilltop, where we get reports on that pretty frequently.
And I'll just comment, I mean, I think that's what the 1915C waivers are all about. It's, Medicaid has to, it's mandatory that we cover the nursing home population, but those optional services in the community, those services in the community are optional. And so that's why the 1915C waivers exist. It allows us to provide services and get federal dollars to help people stay at home and receive services in the community. Again, I think that's the whole goal of those 1915C waivers. We always operate in partnership with the federal government. So there are safeguards and there's federal requirements that we have to have in those programs. So you have to have certain provisions. So and meet those, but that's the goal.
One follow-up, if I could. So I'm sure it's in here, but is part of your plan then to increase the capacity to be able to do that?
But that's the whole end of the wait list, right? That's the goal of what we're trying to accomplish here. And it's going to require staff. It's going to require money from all of us. We have to think about the whole healthcare system. It will generate savings in other areas, but it won't be realized by the Medicaid program. A lot of these folks are on Medicare. And Medicare will realize a lot of those savings from, decreased hospitalizations, decreased nursing, short-term nursing home stays. And so, there will be savings, but it won't come directly to the Medicaid program.
Thank you. Thank you, Madam Chair.
Thank you all for your presentation, and certainly it has been a pleasure to work with your various staff on the various constituent issues that have been brought to my attention. But I do have a few questions, if I may proceed. But one of the things that I've observed and what have I also elevated is that a lot of families in maybe even across our districts use a combination of waivers to address the various gaps and shortages, especially as it relates to skilled nursing, which we know is a challenge, right? And so some families may have seen a removal of these services. I'm thinking particularly as it relates to the community first choice, as it relates to personal assistance services. And so how is it that when there are gaps and families are doing their very best, and even might also consider using private duty services to fill some of these gaps? Why is it that we see these denials or even changes, especially when there are existing gaps, to even meet the needs of the existing waivers that they qualify for?
Yeah, well, I want to first lead off by saying you can't qualify for more than one waiver at a time. So the 1915C waivers, you can only be in one of those at any given time. But by way of being eligible for the waiver, you can qualify for other state plan programs. So to
In
your
that
point,
instance,
that, yeah, for CFC. So as far as denials, an individual has to have an activity of daily living need, and then obviously a supplemental instrumental activity of daily living in order to receive those personal assistance services. So Every circumstance is unique, so we would certainly have to look at the reason for the denial. And, we're more than happy to do that with the constituents to try to help them understand, why that denial may have occurred.
Okay, and if I may ask my other questions, thank you. So what happens when an agency is able to find a nurse, but then that nurse doesn't necessarily take on that case? And so I would like to know, as it relates to what are the steps that are being taken to ensure that there's coverage internally within the department and even across departments. And so how are agencies being held accountable to ensure that there are the necessary placements, especially as it relates to skilled nursing? And what do those mechanisms look like within the department?
Yeah, so provider capacity continues to be a challenge. We work with providers to try to build capacity as much as we can, but that is a real challenge out there. And as a lot of agencies are also recovering from the pandemic, they are struggling to maintain staff. So definitely something that we continue to try to partner with those provider agencies to try to build that capacity. So that someone does have that support that they need. Our programs do have freedom of choice. So participants absolutely can choose whatever provider that they choose and switch at any time. Even if they don't want to switch agencies, if they choose to go with another provider within that same agency, they also have that right.
Okay, and my one last question, I promise you I'll be done. But I also noticed that when it comes to the Medicaid 1915C waivers, that the autism waiver was really the only one that is operated outside of the Maryland Department of Health. And you mentioned that there is some cross departmental collaboration here, but could you expound upon why is it that the autism waiver is really the only one that operates outside of the department? And is there any discussion to essentially move is there any discussions to change that potentially?
Okay. So yeah, I'll take the first part and then I'll turn it to Ryan. But so for the autism waiver, there is an educational component that is required for the children in that waiver. Part of the technical eligibility is that the children need to have an IEP. So our local education agencies are a huge component of that waiver and helping us to operate that.
And Delegate Whitehall, and I'll take a stab at the second one. So as you saw, in addition to the MSDE being the operating state agency of the autism waiver, we have there are 3 waivers that make up the Developmental Disability Administration that Medicaid has authority for, and then the Behavioral Health Administration. There's the brain injury waiver as well. So what I would say to your question is that the current administration is sort of looking at the full suite of waivers across all different operating agencies and taking a look at for their future success. And I'm not just talking about MSD, I'm talking about all of them, where they should actually be aligned moving forward in the future. There are pros and cons against any choice that you might make. The pro being what MSDE is in terms of that's connection with the schools, and as Jamie just mentioned. But we are taking a look at where these things might reside in the future.
All right, thank you. Thank you.
Thank you, Delegate. Turning to the Vice Chair, Jones.
Thank you so much. Thank you for being here with us today. Thank you for the work that you have put in, and clearly your passion for your work comes out in both your findings here and in all of the answers. So I do have a few questions. How long does medical eligibility review take to complete? And is the process for determining eligibility any different than eligibility for long-term care from Medicaid?
Yeah, thanks. So the medical eligibility is different for each of our programs. And it also is conducted by various agencies for those programs. For the majority of them, the medical eligibility is determined by a comprehensive assessment referred to as an NRI, and our local health departments help us to administer those NRI assessments to determine medical eligibility. There are a few counties that we are working with very closely because they are a bit backlogged, and we're supplementing some of their work with our utilization control agent, Telegen, who is assisting with those medical reviews. So as far as a specific timeline, again, difficult to express today, but, I would say that typically it's about a 30-day turnaround for medical eligibility.
And
Okay.
just one,
Yeah.
just add on, I mean, like, the idea with the 1915C waivers is that it can't cost any more than it would have cost in an institution. So the federal government won't put any more dollars to the care of the individual again, than it would have put into if the individual was in a nursing home. Again, that goes back to what's mandatorily required to cover under Medicaid versus optional.
Great. I do have another bite of the apple, please. In 2023, only 26% of those invited to apply actually filled out the application, right? For the waivers, but only 1% of those invited were actually enrolled. Have other options been considered outside of mailed postcards for reducing the registry and actually enrolling Marylanders with a waiver?
Yeah, that's a great question.
There we go.
There we go. That's a great question. So yes, actually, when we mail the invitations each month, we do follow that up with a phone call. So our staff are reaching out directly to try to speak with the constituent or their representative to make sure that they know that invitation has been received, and then certainly helping to direct them on how to fill out the application.
I apologize.
No,
So when
that's-
you're leaving, let's say you get someone's voicemail, right? In the day and age, my parents are in their 70s, and when they don't recognize a phone number due to the unbelievable amount of spam calls that they receive, they often will let it go to voicemail to check rather than. So would you leave contact information so they could call you back appropriately? They know who they're calling and a phone number, and everything is left on as a message?
Yes, yeah, absolutely. Our staff do leave their phone numbers to have return calls. So yeah, and they would certainly walk them through the process once they would, if that constituent would reach back out.
Okay, thank you so very much. Thanks,
Sure.
Cheryl.
Thank you. I'm just going to take an opportunity for 1 second, if I may, Madam Chair, and follow up on what the Vice Chair just asked. So once someone receives a postcard and a phone call and they apply, then they're able to be screened to see if they're eligible. But if they don't apply, how long do they remain on the wait list before they're removed, if at all?
Yeah, that's so someone has 6 weeks essentially from the point in which they're invited to apply to submit an application. After that 6-week period, they are removed from the registry, and that individual would need to then call Maryland Access Point to have their name added back to the registry.
Thank you. Madam Chair.
Thank you, Madam Chair. Delegate Hill.
Thank you, Madam Chair, and thank you guys for the work, for the progress, and for being here today. Got short 2-3. So the first question, and you may have already addressed this, but I really kind of like you to just explain it to me like I'm a 4-year-old, because I really am. What flexibility and ability do we as a state have when it comes to reimbursement rates for direct care providers in particular to supplement or modify what Medicaid has to say? So once the federal government says this is the rate we're giving you, we know we've got a work shortage issue. How and what are the tools we have to make sure that the rates we're giving for that service actually are life-sustaining and what we need to do to make sure we have good people in those jobs?
Yeah, thanks for that question. So currently, there really is no visibility into what happens after those rate increases are passed on to providers. But Ryan did mention that proposed federal legislation or that proposed rule certainly would require the department to find a way to make certain that 80% of that payment is passed on.
Right. So what I'm asking, so I understand the proposed rule that 80% of what Medicaid is giving, but generally what Medicaid is giving is not sufficient, right? So what tools do we have to add to or make sure, or do we not have any flexibility or any ability?
So generally, we have lots of flexibility. But what the state needs to do is come up with the general fund, right? And that's the challenge, right? I've never seen CMS deny a rate increase. They will, if you start implementing cost-based methodologies, they will challenge and make sure that we're using appropriate methodology, and they'll scrutinize those those standards and their practice. But if we were, for instance, not all states gave a 12% increase in a year during the pandemic. We chose to do it. But again, we had to come up with the general fund share of that.
Okay, so we have to match.
We
what
definitely have
asked
to
them
match,
to
and
do.
generally these services are 50-50.
Okay, all right, and then if I may? Okay. There was a question about aging in place. And I know that we passed legislation a few years ago to have the Department of Aging, which is not represented here, to set up a grant program to assist not-for-profits to expand their programs, both in terms of the number of people they serve and the depth of services they provide. They were a little slow getting that set up. Have you seen any impact on the ability of our seniors to age in place and get the supports that they need since that legislation was passed?
If I remember correctly, this was a program that was set up under the last administration that allowed them to purchase for handyman services, et cetera, to come into their home. Is that?
It was supposed to allow those people providing the range of aging in place services, including in-home support care, changes to that, but including health and medical, to be able to provide those services. Sounds like you're not seeing much.
Yeah, I mean, Delegate Hill, I think we would want to ensure that the Department of Aging is, responding to that, just to make sure that we're tracking on the specifics of that. I do know that the Department of Aging recently did make some awards to community nonprofit providers that were working in these spaces. I know one specifically in a former life that I worked on in the J. Van Story branch in Baltimore City that they're providing these funds for. So I do know that they are issuing awards, but certainly would want to coordinate, the connection to this work as well. That is also why, right, we recognize as a department that yes, aging has been our partner in this space for a long time. There's no way that they can't be. But under Secretary Roke's leadership and Deputy Secretary Crawley and her team that she has brought on as aging experts, we want to ensure that we're in lockstep and locked in arms in terms of this work, because you just have to be.
Yeah. Okay. Thank you. And I guess this is really a question for the chairs. I know the Appropriations Chair and Vice Chair had asked about the process, the intake process, and the specifics. And I, for one, am also interested in that. And I'm wondering if we could impose upon these folks to set up a time where we could be walked through, not just what the intake process is, but what happens on the other side with the folks who receive that information, so that we could have a better idea, maybe offer some suggestions of how to make it work better.
That's a great suggestion. I think there's probably some bipartisan interest in this, given the immense amount of excitement on this briefing here today. I'd be happy to take the lead in coordinating with members who are interested in participating in such a conversation.
Happy to
with our
collaborate.
partners. Thank you. Thank you for that recommendation.
Thank you.
Thank you, Madam Chair. I too, as I'm aging, my mom is aging, she's 91. And so I just recently went through this program to get her some help. And there's some good things about it, and there was a few bad things about it. One, when you get on the registry, which I wasn't sure that's exactly what it's called, when you actually send a letter or a request, to fill out the application, receive that, it only lasts so long. So then I had to because I was like at the very end of session last year when this happened. And so I had to get an extension. It was fairly easy. But then you go through the paperwork. Paperwork is very, very hard, but I get it. You're looking at finances and all the information. But, thank God my mom and, her husband had me to go through all those processes. I had to go to Social Security. I had to wind up getting a new card. So you have to go physically to those places. Both of them, one's paraplegic and paralyzed. And then my mother's bedridden, so they could go nowhere. So, if you could get assistance from the caseworker, maybe to kind of
I don't know, follow through and kind of help the families, through that situation. Plus they're working full time or what have you. So, that was one issue. It was a lot of work. And then, they do look at it, they get back to you, don't necessarily tell you what it is, that you need, but then I did get it. So then you go back and you're working on that. And then while you're getting the information, I write a letter saying, I'm working on getting this information. Meanwhile, they already sent you a denial. It's like, gee, you could have told me that ahead of time, instead of me, again, going through all that information. But so basically in the end, she was denied. And the reason why was for financial purposes. They just went over the threshold. And the reason for that, so I guess my main question is there any program out there that you go by individual opposed to a joint? Because you don't know the situation that's going on with the spouse and what has happened and, what could have occurred, with their finances or what their, what their situation is now. And through the whole process, the caseworker that they gave me on the paperwork, I called several times, left message, never received a phone call, never could speak to that person in person, which is very, very frustrating, because then you got to wait another couple of weeks to, try to send a letter and maybe they'll respond. Now the caseworker that came to the home and all the people that came to the house was absolutely phenomenal. Great job. And which that is good too, because the whole medical process is happening at the exact same time. So that certainly does save time. Which was very beneficial. And, definitely under the medical portion for both of them, actually, but we were only filling it out for my mom, meet the criteria by leaps and bounds, just a little bit over the financial threshold. Is there anything that we offer that would take individual salaries? I mean, the one person that I'm speaking of makes $600 Social Security. That is it. That's her entire life. So, to have that, and then you have the situation over here because they, obviously are still married and together, and he makes a little more from his Social Security. Is there anything that you can offer as a waiver as individual?
So we don't have our eligibility expert here,
Okay.
but what I can say, right? So the on the long-term care side, which is different when you talk about eligibility coming through the exchange, the young adults, you do have asset tests. And within those asset tests, they should have provisions where they protect, the spouse, to allow you to disregard spousal income, to protect the spouse, keep their home, etc. I think generally you cannot waive the income tests under these programs. That's, again, we have to answer to the federal government. It's limited to 300% of SSI. And, there's always that penny or two that's over it. We have what's called, which Jamie talked about, is the increasing community services, ICS. And there's two provisions in there. So it allows basically individuals who are in the nursing home for 90 days, who, again, when you can pay for your cost of care when you're in a nursing home. When you move to the community, there's not that option to pay towards the cost of your care and be eligible for Medicaid. That program does allow it. So you had to be in the nursing home though first, and then you can transition and start paying towards the cost of your care. And then it also allows, let's say you're on a 1915C waiver and all of a sudden you had a slight change of income that's going to knock you off the next year. We protect you and allow you to stay on that program, and we allow you to pay towards the cost of your care so you don't lose coverage.
And I know this was kind of personal, but I've also had constituents that talk about, people worked all their lives and then they're in a situation to where, they're over that. Now I get it. We can't, we have to come up with a certain, period break off. But if you could do it, in some situations, if you could do it by individual, and maybe have a caseworker that kind of look at the family situation and see why, you don't have that amount anymore, really, of what, the paper says or this or that. Okay, well, thank you. That was very, very helpful. Thanks. Thank you, Madam Chair.
Thank you. And I'm going to ask, given that you have this as a recurring concern, if you could connect Delegate Riley with the eligibility expert and share with the joint committees the resources, who we would contact if we have a constituent concern that is not confused about the system, doesn't understand the eligibility, somebody that can walk them through, because we know that healthcare is a very complicated landscape. So thank you for that. Delegate Alston.
Thank you. Slightly outside of this, but I'm wondering if you all could look at an 1115 waiver to help people with low to moderate income who are not necessarily meeting that poverty threshold to assist them with long-term care needs. Maybe something that Matt can look at in the future.
Yeah, I mean, that's a big ask and big discussion item. You know, we have done some expansions under the 1115 waiver to cover non-Medicaid eligible individuals. So, you know, I think that's something we can talk to you all about. Now this is where it gets really complicated, right? We have, through an 1115 waiver, you have kind of built up some savings, and I always kind of say they're kind of funny savings, right? We negotiate with the federal government. We say it's going to cost individuals to be served in managed care less than what they would be in our fee-for-service program, because our 1115 waiver is mostly a managed care program. And so we've accumulated over time some of these savings. Again, it's over in this kind of funny bank, let's say, and you can apply for, then you can use that bank to draw down federal dollars for services and populations that you normally aren't allowed to cover under Medicaid. Now, again, going back to Delegate Hill, you have to come up with the general fund share, but you get to draw down on the federal dollars and you get that, but you still have to come up with the general fund share.
Yeah, I think it would be worth looking into for the future, not necessarily right now, because I think we're all going to be facing this at some point, and we know that the long-term care crisis is set to bankrupt our country if we don't figure out how to deal with it. So if we could be proactive and look into if that's a possibility, I'm not sure if it is, but to the extent it is, it would deal with some of the income issues that a lot of people face, because paying 10 grand a month isn't always affordable to people. Thank you for the opportunity to ask the question.
Thank you, Delegate Alston. Obviously, you know, the short answer is it's complicated. It's very clear that it's complicated, and we really appreciate how much work and effort you are putting into this to address our questions, our concerns. I think what I'm hearing is some overarching concerns that I hope that we continue to work on. There is a question about who the oversight and authority is, how we're determining quality of care. And I'm going to ask a question in just a moment about the nexus of the various quality assurance agencies that we work with, and sort of how this all works together. But also to Delegate Chisholm's question, you know, there's a question of where are the barriers? Is it in staffing? Is it in the health workforce? Is it identifying efficiencies? Is it bureaucracy that's built into the system? So thank you for continuing to try and untangle that. And my overarching question, and it speaks to Secretary Moran, what you said about the continuum of care, is where are the entry points baked into the system? Are those something that folks have to self-identify, or do we have opportunities where we're really making it clear that these services are available, that you should be applying, and where are those entry points throughout the system? So what is the nexus of our various quality assurance agencies and oversight, and where are those entry points for continuum of care?
Yeah, and thanks for that question. So the entry point for the programs primarily goes through our No Wrong Door alternative, which is our Maryland access point. sites. So there are a number of those. The Maryland Department of Aging oversees the Maryland Access Point sites. So as far as the quality of care, I'll just kind of mention that in the 1915 C waivers, we do have to establish performance measures. So those performance measures assess health and welfare and a number of other different measures that are within those. And on the third year of the waiver, so typically a waiver, a 1915 C is approved for a 5-year period. And in that third year, we do have to provide a report to CMS, to the feds, to let them know how we're performing in those measures. Certainly thinking about some of the things that we see, provider capacity is huge. Definitely trying to build that is critical to making sure that the services, first off, are able to be delivered and that quality services are delivered. So I would say that provider capacity is definitely something that we all have to work on and get more folks into the field.
Thank you very much. And thank you to the chair for allowing our members to have some latitude. This is a very difficult and complicated landscape, and I think we're all very passionate about it. That said, we are honoring the rules of our host committee. So thank you all to our members for checking in with us to see what the rules were today. And thank you, Madam Chair.
Thank you, Madam Chair. I think if I read between the lines, I think she's saying, don't get used to it. HGL members, when you go back to your home, home committee, don't do what you did in here. But I'm grateful that each of us, everyone here has been so engaged. And I do have just a couple of quick questions, though, if I may, before we close out. So this first one follows on Vice Chair Jones's questions around Medicaid medical eligibility. In your presentation, you all discussed some of the bottlenecks around plans of service.
Yes.
Is this different or the same?
It is different.
Okay.
So there is the medical eligibility process, and the plan of service is more of I would consider it a technical eligibility, although I recognize that, it certainly seems medical because it's the services, but really it's more of the technical eligibility component.
Okay, and is that a requirement of CMS that we have a plan of service in place, or is that a Department of Health, or is it statutory? And does long-term care Medicaid or other programs require this component?
Yeah, it is a requirement in our authority from the feds, and it does need to be updated annually. That's the requirement that they have established for us. And if I understand what you mean by long-term care, so you're referring to like nursing facilities?
Yeah, so an
Yeah.
individual who is in Medicaid through the long-term care Medicaid program.
Yeah. So it's not the same sort of plan of service. Of course, there's a care plan, but it's not, I wouldn't say it's comparable to what someone would be receiving in the home and community-based services. Yeah.
Okay, so if I'm hearing you correctly, you're saying that CMS requires this.
Yes.
Okay. I'd love to have an offline conversation with you about this because it seems like it's a very big bottleneck in this. We've heard from Montgomery County as well about how lack of staff capacity to provide annual plan of service updates and the on the state side to approve them has been really challenging. So would love to talk with you privately about that as well. So on the same note, you note that staffing is a big challenge as it is across all of our agencies. The department has done a really great job in backfilling and rebuilding our department or the department in the 1 year you've been there. So what is your plan, your staffing plan for the Department of Long-Term Support?
So Chair Shetty, I just want to comment too in the plans of service, and you rightfully acknowledge, the backlog that exists there. I say I want to comment, and I'm certainly happy to comment offline, but Tricia and Jamie know that since my arrival, I've been relentless to think about ensuring that we have both a short-term and a long-term plan that's been in place. Jamie's slide, which did it in terms of injustice of the work that has been done in terms of remediation for that, has been both, yes, we present on a JCR every month in terms of the staffing issues related to the plans of service review internally. What was abundantly clear that there was absolutely no way that an internal capacity based on our staffing model is going to work. What's also noted in that report for that backlog is that we successfully awarded a new vendor. And then we modified that vendor for them to take both the new plans as well as work on the backlog of those plans. And that work is set to take place in March of 2024. I have also been giving the team, we have been giving the team the authority to work on automation. You will note, I got happy about it. You will see a significant drop in our most previous JCR report because we did put in some automated processes that would put a certain level of plans through based on algorithm, and that will happen on a monthly basis. And there are more technology enhancements coming. This is something that, you know, we are watching very closely, and that we're trying to put the necessary resources behind. I don't make promises that it's going to be solved overnight. The backlog is too long for that to happen, but it's something that we are relentlessly focused on. I've been such on a tangent of that, I forget your second part of the question.
Your staffing plan.
Oh yeah, staffing. So, you know, I think we are, as administration and under Secretary Herrera Scott's leadership, we have been enormously proud at the department to move from, I think, a 15% vacancy rate when we started at the department to now 10%. In Medicaid, I think the vacancy rate was just north of that for the whole department when we started. And now recent numbers, I think I will see will be about a 12% specifically in this office. This office in the area of eligibility based on the staff composition is where we tend to trend a little bit higher than Medicaid overall. We know that in the proposed budget that there are some net new resources in terms of thinking about the infrastructure for the Office of Long-Term Support Services, specifically 8 new PINs that will be dedicated to support this department and team. And we are continually looking at where in this particular space we can move from contractual to merit PINs as well to solve retention of the space. Just like the long-term workforce that we talk about in terms of the provider service delivery, this is an area also that has experienced, you know, sort of those post-COVID implications, and it's something on our radar to be able to restore. We are trying to do a much better job in terms of our recruitment, in terms of reaching out on all forms of social media or other type of recruitment strategies, bringing back job fairs to try to recruit individuals. We've taken a look at the leadership structure about how we navigate and how we put the infrastructure of these programs in this office moving forward. There are 8, Tricia, there are 8 offices within Medicaid, 8 directors. This is the one that has been the most priority for our administration to think about since we arrived on day one.
Wonderful. That's great to hear. I just have one last question. So this is a bit of a follow-up to Delegate White-Holland's questions. So in yesterday's MDH budget overview hearing, DLS noted that the department has identified availability of placements and provider shortages as one of the barriers to getting people off of the wait list. This is I've been trying to track and follow this issue for a little bit. I don't recall seeing this as being one of the listed challenges in prior analyses that we've had on the budget. So this was really interesting to me. So I just want to understand whether there's a requirement or a condition on eligible individuals to have an actual placement available to them in order to be approved to use the waiver. And sort of relatedly, do people lose their waiver if they lose their services? Like if let's say, there's a staffing shortage in a home-based nurse provider, there's only one company that serves the area, they're unable to serve this patient. What happens? Does that patient now lose eligibility for the program based on this because of a condition that exists?
Okay, there we go. Thanks for that question. So there does need to be a provider listed to provide the services on the plan of service to complete the enrollment process. So that is required initially. However, once someone is enrolled, if they do lose that provider, typically if you're not receiving services within a year, then that person is disenrolled from the waiver. Understanding the provider challenges that we're certainly dealing with, we've not held fast to that 1-year disenrollment, making sure that folks do have an opportunity to secure a provider.
Okay, thank you. And then just curious if there are any other Medicaid the Medicaid program as a whole or any other waivers that have this requirement?
So one of the federal requirements of a 1915C waiver is that you have to have an independent case manager. And so that's a federal requirement. And for any of the 1915C waivers, you have to have an independent case manager that helps you manage your services. And that's, obviously, if you're looking at some of these numbers on the registry, it's a lot of folks that we're going to have to be placing, right, in with case managers, and we're going to have to try to increase that provider level in order to serve these individuals. And I think generally, if you look at, I think hopefully one of the things that we've been able to describe here is how complicated the enrollment process is and eligibility process, which goes back to the earlier comment about these registries, and really having people that can utilize those services on those registries, because it's a lot of staff time, and then it's and all of those pieces cost money, right? So it is a federal requirement.
Got it. Okay, thank you. Seeing no further questions from colleagues around the table, would you like to do closing remarks first?
Certainly.
Okay.
I just want to thank you again for the opportunity to partner with you. This is a very complicated issue. To Delegate Alston's point, we are looking at a huge aging population that wants to age in place, that wants choice, and to Madam Chair's point, we still have massive inequities that we recognize in the system, and we've had conversations about the fact that we're still reconciling modernizing our entire healthcare system with the fact that it was built on the assumption of a caregiver within the family, whether it was a spouse, whether it was a child, and we are going to have to figure out how to move away from that model. So I just really appreciate the work that you're doing, and the fact that you've not, this administration is very new and very young, and you're really working hard to address some of the longstanding issues that we have continued to reconcile with in this committee and in appropriations. So thank you for being good stewards of our most vulnerable populations and good stewards of our state dollars.
Great. And I just want to echo thanks and gratitude for this excellent conversation. As you can see, there is a lot of bipartisan interest in these programs, and we're just really grateful to partner across committees, and then also with our Department of Health colleagues to ensure that all of these programs work to benefit patients throughout the state. So again, I just want to reiterate that while we're so grateful for the progress that the administration has made in such a short period of time, I think even just through this conversation today, we've identified some significant areas of improvement that are needed, not just to, fix this broader, systems issue, but also to help address some of these massive health inequities that exist in long-term care in particular. So, we know the system just needs to be more transparent. Patients and caregivers, they need to be able to understand the process. They need to know who they're to call, or even better, where online they could look to find out where they are on the list. So the list itself, it needs to lean on all of the data that we have available to us as a state. MD Think is a massive annual investment that we are making, and it includes death registries. So working together across DHS and MDH to periodically scrub the list, it would help keep things moving so that we can ensure that the people that are in critical need of care are able to access the services available to them under these programs. But we're all really excited to continue this work together with you and your team. So again, just thank you so much for the conversation. Thank you, committee colleagues, for your enthusiasm. And with that, we are adjourned. Happy Friday.